Hello, and welcome to the Osteogenesis Imperfecta Foundation's podcast series. My name is Tracy Hart, and I'm the CEO of the Osteogenesis Imperfecta Foundation. On each podcast episode, the OI Foundation brings you information about the diagnosis and treatment of osteogenesis imperfecta, presented by an expert in the field of OI and rare bone disease. The podcasts are a part of the ongoing educational effort of the Brittle Bone Disorders Consortium, part of the National Institutes of Health's Rare Diseases Clinical Research Network. The professional education activities of the Brittle Bone Disorders Consortium are led by the OIF. Our podcast today will focus on best practices for using anesthesia in patients with OI. And so we're very excited to have with us today Dr. Lilach Rothschild, pediatric anesthesiologist at University of Illinois Hospital and Health Sciences System and staff pediatric anesthesiologist at Shriners Hospital for Children, Chicago. So welcome, Dr. Rothschild. Thank you so much for being with us today.
Thank you so much. I'm very happy to be here and joining you guys today, and hopefully I can shed some light on some of the anesthesia challenges when taking care of OI patients.
Excellent. Well, one of the reasons we really are excited about this podcast is we get a lot of questions here at the OI Foundation about anesthesia with upcoming surgeries and surgeries that aren't expected. So just real quickly, if we could kind of level set here, can you tell us, we know people with OI of all ages may undergo many surgical procedures that require the use of anesthesia. Can you give us a short overview of what it means to have general anesthesia and what happens to your body when that happens?
Sure. So general anesthesia implies a couple of things. It implies amnesia, which is no memory formation, analgesia, pain control, and involves complete control of the sympathetic, which is the automatic nervous system. General anesthesia is commonly achieved by the use of a combination of medications that may include inhaled volatile anesthesia agents as well as injected medications through the IV with or without the use of muscle relaxing medications that help the muscles relax in the body. And ultimately all of this creates an unconscious mind and the ability for the surgeon to perform surgery. General anesthesia suppresses many of our body's normal automatic functions, such as those that help control breathing, maintain a normal heart rate, help with effective blood circulation, and a lot more. And it's common for the patient's entire body to be relaxed under general anesthesia, which necessitates that the anesthesiologist assist the patient with their breathing and ventilation and other normal body functions that occur when the patient is normally awake. The anesthesiologist maintains constant vigilance and monitors the patient's heart rate, blood pressure, oxygen levels, exhaled carbon dioxide, temperature, and a lot more. And our job is to maintain this normal level of homeostasis within the body. And we oftentimes relax the patient's body and muscles to help assist with the breathing throughout the procedure. And in order to do this, one of the first things we do after we induce general anesthesia is we place a breathing device, which is oftentimes either an endotracheal tube or something referred to as a supraglottic airway device in the patient's mouth that either goes through the vocal cords or rests above them to help with the ventilation process. Sometimes this can actually cause a sore throat when the patient awakens from anesthesia, so it's important to know that this is occurring. And I'd like to just talk a little bit about the different phases of anesthesia, more because I'd like to make some distinctions between the adult population and the pediatric population. General anesthesia can be broken down into three phases: the induction phase, the maintenance phase, and the emergence phase. The induction phase of anesthesia is the process of actually putting the patient to sleep, and the maintenance phase, just like it sounds, is maintaining a patient under general anesthesia with either IV medication or inhaled anesthetics. And then the emergence phase is, again, waking the patient from anesthesia, which both the maintenance phase and the emergence phase are very similar for both adult and pediatric populations. But the induction phase is actually the one that differs between both patient populations. So I'd like to mention these differences again. Adult patients generally have an IV before being brought back to the operating room, and this allows the anesthesiologist to administer anxiety-reducing medications through the IV. Once the adult is brought back into the operating room, then monitors are placed. They breathe in oxygen, maybe the volatile anesthesia agents, as well as the medication through the IV, and then anesthesia is induced and the airway is secured with one of our breathing devices. But in children, especially infants and toddlers, they don't allow IVs to be placed in the preoperative holding area. And so an anesthesiologist may administer a preoperative medication, usually in the form of a slightly bitter-tasting cherry syrup, and on occasion an intramuscular injection to help decrease their anxiety, induce some amnesia, and allow the anesthesiologist to successfully separate the patient from the caregiver. Once the child's back in the operating room, the anesthesiologist will place the monitors on him or her and usually use some distraction techniques or imaginative play to help keep the child as calm as possible as they breathe through the anesthesia mask and circuit, which is delivering the inhaled anesthesia agents. And then once the patient is induced and unconscious, then the IV is placed, and only then is the airway secured. So again, that process is different, and it's important for parents to understand this when they are saying goodbye and kissing their children and not quite sure what's going to happen next.
Very interesting. Excellent information. Thank you. And so just listening to you, I'm even more sure that this is a partnership between the anesthesiologist and the patient and the parent. So what types of precautions should people with OI take if they have planned surgery coming up that involves anesthesia? Should they meet with the doctor prior to the procedure to discuss what will happen? What kinds of questions should a person or parent ask? I mean, what do you suggest in that situation?
Okay, so the perioperative care of any patient with OI, especially children, can be challenging, beginning with their preoperative evaluation and through their entire anesthetic and up until they're discharged from the hospital. But I do think with careful planning, as you mentioned, a partnership between the anesthesiologist, surgeon, nursing team, other healthcare providers, OI patients, and parents, I think these patients can be cared for safely and efficiently and effectively. But it is important to coordinate this care and make sure that everybody is on board. Also, as these patients commonly come back to the operating room for multiple procedures, it's critical to allay their fears and address any concerns that they or parents may have at their first surgical and anesthesia encounter, again, as it will likely be the first of many. And ideally, if possible, care should be administered at a center where the care team is familiar with OI patients and has experience with this patient population. But to more specifically answer your question, I don't think there's any specific precautions that OI patients can take themselves prior to a planned anesthetic and surgery. If a patient has had anesthesia at a particular hospital, it might be helpful for them to know if their care posed any challenges prior to undergoing additional anesthetics, especially if their future surgeries may be performed at different hospitals that may have less experience with OI patients. So again, there's very little that they can do on their own, but I would like to discuss some of the issues and concerns that anesthesia providers should have in mind when caring for OI patients, and that OI patients and families should be aware of with respect to their care so that they can pose these questions to their providers. And an anesthesiologist who has experience caring for OI patients will likely be concerned with the following issues, and I'm just going to list them and then I'll go through them one by one. The potential for any airway challenges, potential for respiratory or ventilation difficulty, potential for cervical spine instability, potential for coagulation dysfunction or disorders, potential for any cardiovascular problems, potential for difficult IV placement, and also the tendency for higher resting temperatures or hyperthermia. So now to just break it down a bit and go one by one a little bit more thoroughly. With regards to the airway, as part of the preoperative assessment, the anesthesiologist will assess the airway and ascertain whether or not it may be difficult to place the breathing tube once the patient has been induced under general anesthesia. Generally speaking, with the abundance of anesthesia intubating devices and all of our video assist devices, which is extra equipment that we may use when we're anticipating a more challenging airway, this is actually easily achieved, but does require careful positioning of the patient on the operating room table with the help of the operating surgeon and possibly even having a second anesthesiologist at hand to help facilitate with the intubation. So having an extra set of hands is important, especially if it's in a facility where they don't usually take care of OI patients. With regards to ventilation, in Dr. Sandhaus's podcast, he goes into a great deal regarding the pulmonary involvement of OI patients, so I only want to briefly mention some concerns, and that is that generally speaking, anesthesiologists are aware of the potential ventilation challenges if they notice a physical deformity in the patient, such as kyphoscoliosis or barrel chest. However, in the absence of these physical characteristics, the anesthesiologist may not actually appreciate any lung abnormalities. But we know from Dr. Sandhaus that the lung abnormalities may occur even in the absence of these physical deformities. So if the patient has had any pulmonary function testings, also called PFTs, or any recent decrease in activity or shortness of breath, then this is information that would be very important to share with the anesthesiologist. It's not necessary to undergo new pulmonary function testing before a procedure, but again, if there's any change in activity or change in baseline shortness of breath, then that kind of information is very important to communicate. With regards to the cervical spine, if a patient has a history of basilar invagination or basilar impression, they should alert their anesthesiologist so that they can take the necessary precautions when securing the airway and minimizing neck extension. Both of these medical problems can cause the cervical spine to be unstable, and so prior to anesthetizing a patient with OI, the anesthesiologist should perform a gentle exam of the cervical spine and assess for pain and assess for normal range of motion. With regards to coagulation disorders, specifically involving the platelet function that has been implicated as being potentially involved in coagulation disorders in the OI patient. And while it's not completely understood and doesn't necessarily affect all patients with OI, this may pose problems in those patients who are having larger surgeries with larger anticipated blood losses. And again, routine coagulation workup or a hematology consult is not necessary unless the patient has a documented bleeding history, but it's necessary for the anesthesiologist to know that they may run into problems, and this has to do with inherent problems with abnormal collagen on platelet endothelial cell interaction capillary strength, resulting in capillary fragility and ultimately increased bleeding. And generally speaking, the labs are actually normal in these patients. So you're not going to necessarily find changes in or abnormalities in the lab studies. With regards to cardiac abnormalities, patients with connective tissue disorders such as OI may have diseases involving aortic root insufficiency, aortic root dilatation, or other valvular disorders. And so if an echocardiogram has been performed, the results should be shared with the anesthesiologist as well as any recent correspondence from the patient's cardiologist. Again, these conditions are usually only seen in the older OI patients. In my experience with the children at Shriners, I have not yet seen any children with any cardiac abnormalities. Again, this is more in the adult OI patient population. And then just briefly with regards to IV access, we know that it may be challenging in children, again, probably more so than in adults, just because of the limb deformities. And so when speaking to parents, I usually mention the small risk of any additional fracture from IV placement. And if an extremity has been rotted in the past, I will actually attempt the IV on that rotted extremity because it will have an even lesser chance of fracture from an IV tourniquet. I do want to make mention, though, that I looked at our Shriners data in Chicago over the last 8 years of our surgical experience, and many patients had surgical tourniquets, which are tourniquets placed at high inflation pressures to decrease the amount of bleeding used during a procedure, decrease the amount of blood loss during a procedure, and not a single patient had a fracture on that particular extremity. So I know that anesthesiologists and parents alike are always concerned about the placement of a tourniquet for IV access, but I do want to mention that, again, with surgical tourniquet use at our hospital, we have not had a single fracture just due to surgical tourniquet, which is on for much longer at much higher pressures. So again, a fracture due to an IV placement is extremely unlikely. And then lastly, I want to mention that patients with OI have a tendency to have elevated temperatures because of increased metabolism, which is likely related to elevated thyroid hormones. So knowing about these this predisposition is important when undergoing anesthesia because most patients actually lose heat in the initial time of exposure in the operating room, and the anesthesiologist uses active heating techniques such as warming the room, warming the fluid, using special warming devices, special warming blankets to keep the patient warm. But these OI patients have this baseline elevated temperature, and their temperature should be monitored from the moment they come into the operating room, because the anesthesiologist might actually need to use cooling techniques to keep their body at normothermia, especially if their entire body is covered with the surgical drapes and there's just a limited surgical exposure site. I do want to emphasize that this increase in temperature is not at all life-threatening. There are some people that have asked questions about the risk of malignant hyperthermia, which in the past, like 30, 40, 50 years ago, there were several publications about malignant hyperthermia in OI patients. But I want to emphasize that OI patients are not at increased risk of malignant hyperthermia, also called MH. MH is a life-threatening hypermetabolic syndrome of continued muscle contraction that, if not recognized or treated immediately, can be life-threatening. But again, OI patients do not have any increased risk or susceptibility to this condition. So with regards to carrying paperwork or documentation, again, if there's any information regarding the issues we just discussed, then I think it would be very helpful for an anesthesiologist who might be encountering a patient for the first time under emergency conditions to present this information to the anesthesiologist so they can appropriately care for the OI patient under the emergency procedure or surgery.
Mm-hmm. Excellent information. Thank you so much. I mean, it's so important to know your history as well when you talked about, an unplanned surgery. Excellent information. Thank you. So we get questions here sometimes, Dr. Rothschild, about minor complications from anesthesia. We hear people talk about nausea, fatigue, those kinds of things. Is there anything you do as a physician to help with those types of issues?
Sure. So I'm going to talk a little bit about postoperative nausea and vomiting and fatigue, and then also some more commonly encountered complications, but very minor. So again, first I'd like to mention that it's extremely rare to have any kind of serious complication following general anesthesia, but it's more common to have some of the discomforts that you mentioned. So with regards to postoperative nausea vomiting, which is commonly referred to as PONV in the anesthesia literature, it is common following general anesthesia, and it can occur in up to 30 to 40% of all patients. It usually occurs at home within 24 hours of an even uneventful discharge from the hospital, from an ambulatory surgery center. The etiology of postoperative nausea vomiting is multifactorial, to say that there are several things that can contribute to its presence, and it can be associated with the anesthetic and analgesic agents, the type of the surgical procedure, and some patient factors that we can't actually control, such as if the patient has had a history of motion sickness. Women patients are more prone to having PONV, and actually specific surgical types are more prone to having PONV. So we can use medications intra-op, which we do routinely, and also patients can take preoperative carbohydrate drinks, which is there's new evidence that shows improved outcomes when patients drink Gatorade-like drinks clear with no pulp up to 2 hours prior to surgical incision, and really even up to 12 ounces of this fluid. So this has been shown to be extremely beneficial and is being pushed in many anesthesia settings. With regards to fatigue, as you begin to awaken from general anesthesia, you may experience some confusion, disorientation, or difficulty thinking clearly, and this is all normal. And it may take some time, a couple of hours, maybe even by the end of the day, before the effects of general anesthesia are completely gone. But there shouldn't be any long-term cognitive delays. Generally speaking, this is only may be present in an elderly patient with already some neurological compromise. It may take them longer to return to their baseline cognition, but in otherwise healthy adults or pediatric patient, the return to their baseline cognition and their usual daily activities should occur within 24 hours. And then just to address a couple other risk factors with general anesthesia that I always address when going over the anesthesia risks is airway injury, probably the most common. And that's because we insert breathing devices, again, endotracheal tubes or supraglottic airway devices. Also, we insert oral nasal airways or gastric suctioning devices, and all of these can risk airway structure damage. And the common complaints are sore throat and dysphagia, which is difficulty swallowing. But these are generally self-limiting and usually go away within 48 hours. If they last longer than that, then we want to know about it. But also relating to the airway is the potential for dental trauma. And in a study of 600,000 surgical cases, the incidence of injury requiring dental intervention was approximately 1 in 4,500. So OI patients we know already may have dentinogenesis imperfecta, and so they may be at even increased risk for dental injury. So it's important to review the dentition with the anesthesiologist prior to anesthesia. And then lastly, I'm just going to quickly mention a phenomenon called emergence delirium, which is commonly seen in pediatric patients. And this is a disturbance in awareness of environment that happens in the immediate postoperative period. And we know that it's very closely linked to the patient's anxiety, preoperative anxiety status, and parental anxiety. Also, if they have a lower emotional developmental age, they may be at increased risk for emergence delirium. Pain control can contribute to emergence delirium, and so it's important to try and address this preoperatively and try and prevent it and have the patient emerge in a quieter way without these delirium type behaviors that are very distressing to both the patient and the parent.
Excellent, thank you. So we have a couple of minutes left, and I'd love you to comment on what advice you can give to our community and to surgeons about partnering with their anesthesiologists, any words of wisdom that you have.
Okay, so I think because OI patients will be coming to the operating room for repeated surgeries throughout their life, it's important to try and target the pain management and pain pathways via several anti-pain modalities. And I'd like to spend a little bit of time focusing on some of these adjuncts to general anesthesia, which include preemptive analgesia regimens, which is a hot topic now in anesthesia, and it involves the oral administration of medications before surgery to help minimize the use of opioids throughout surgery and after surgery, and also regional and neuroaxial anesthesia. Regional anesthesia involves in the injection of local anesthesia, similar to what a dentist may inject inside the mouth for any minor oral surgery, and it's injected around nerve bundles that supply various parts of the body, specifically the upper and lower extremities. And neuroaxial anesthesia is commonly broken down into several types: caudal anesthesia, epidural anesthesia, and spinal anesthesia, and involves the injection of local anesthesia into the epidural or spinal fluid space to numb up the nerves that supply the abdominal region, the pelvic region, and even both lower extremities. So the goal, again, is to minimize, if possible, the use of opioid medication, because we know that there's an opioid, there is a problem in the United States with opioid use in general. And so to try and minimize the exposure and minimize the use in the operative course is extremely important. There's also side effects that hopefully we can avoid with decreased opioid administration, such as less nausea, vomiting, less respiratory depression, less itchiness, having the bowel function return to normal a little bit more quickly. So again, trying to decrease the opioid use and using all these adjuncts hopefully can help. Some of the oral medications that are used preoperatively, which are not necessarily suitable for every patient or every surgical procedure, are Celebrex, acetaminophen, gabapentin or pregabalin. Again, they significantly reduce the postoperative opioid requirements, and these medications can be resumed immediately after the patient wakes up. Again, this is not necessarily appropriate for all patients or all surgical procedures, but something to definitely discuss with the surgeons before surgery to see if this might be beneficial and helpful for the patient's postoperative course. I think I probably have 5 seconds to quickly just mention that I might not even have it, but there's always concern about upper respiratory tract infections. And so just real briefly, if a child has an upper respiratory tract infection, it would be important to discuss this with the surgeon and to consider delaying the procedure for at least 4 weeks to try and minimize any airway complications. And I have a lot more to say about that, but I think we're running out of time.
We are. We have about 1 minute left, and I just would like to wrap up and thank you so much for this information. This is wonderful. And we're going to have you back to do another podcast, Dr. Rothschild, because there's a lot of information here that's so valuable. So thank you so much. You can end with whatever you would like to end with.
Thank you so much for having me. It's really an honor to take care of OI patients, and I am fortunate enough to partner with many parents when caring for OI patients. And if there's anything that we should be aware of as anesthesiologists, then it's important also for parents and families, patients, to bring it to our attention, because again, it is a partnership, and it's important that we take all of the concerns very seriously, and we want to try and facilitate and make for as productive and as seamless and smooth of a process for every anesthetic and every procedure that patients go through.
Wonderful, wonderful. Thank you again. Thank you for your time, and I'm sure we'll have a lot of questions to send your way once people start listening. So thank you again.